respected chairperson. My talk is already finished by a question which one thought that HbA1c is a really reliable marker of the chronic complication or disease progression. I want to ask the audition two things. A small frequent diet is better, or second, take a too large meal, which will give the metabolic stress in the body. Second question, if the water supply in your house is a constant, if it's suddenly a pressure of 1 hour or 2 hours, or suddenly with low pressure, which reason is good? Especially I want the female doctors. If you understand two things, then we can understand that HbA1c is not a wholesale, a reliable marker of the chronic complications. One is water supply, another is the diet stress. That is the Indians, we eat two major meals and will give the lot of metabolic stress in the body. So let's see in 10 minutes what thing. This part is got by Dr. Ashish, and the HbA1c is a specific glycated hemoglobin and results from the attachment of glucose in N-terminal value of the hemoglobin beta chain. Disease trial says it should be less than 7% in order to prevent the development and the progression of the chronic diabetic complications. So, but whether it is a reliable, but which I told you the two examples, one is the small frequent diet and another is the water supply. These are two cases. That is the Ramesh, that is 48 years old, diabetics more than 10 years with minimum glucose excursions with little variations from the preprandial to the postprandial glucose level, but rare, very rare episode of hypoglycemia. Second case is Suresh, 48 years old, diabetes more than 10 years, had a wide fluctuation of the blood glucose level. Sometimes this patient has a hypoglycemia, suddenly has a hyperglycemia. Now these changes is the blood glucose reflects over the time, and that is known as the glycemic variability. The various studies, even from the Wikipedia disease trial, they clearly mention that HbA1c is not a wholesale marker of the chronic complications. So diabetic patient with overall stay on 29% of the day in hyperglycemic range, that is more than 180 milligram percent, 29% of the day. Even those who are well controlled on the diabetes, the PP value, that is postprandial blood glucose, is more than 140 milligram after the 50% of the meals. And the third, the complete categorization of glycemia is the best studied by the CGMA studies, where how much is the postprandial load and how much patient develop hypoglycemia. Therefore, it is essential to identify the distinct post-meal period of the hyperglycemia and intraday glucose variability. The variations, the changes in the rules in the life. So glucose variations, they are not limited to the postprandial hypoglycemic excursion. Such fluctuations commonly seen in type 1 diabetic patient, even the type 2 diabetic patient, as the disease progression in the type 2 diabetes, especially patient are taking insulin. The non-insulin dependent diabetic patient can also experience such peak and trough pattern with acute glucose variations. Peak basically respond to the maximum value after the meals, especially the mid-morning, while the trough they are observed with interprandial period. That one should know what is the glycemic variabilities. Why the glycemic variability is important? That's very important. There are two patients who have the same HbA1c level, the different microvascular outcome. We have seen clinical, lot of patients HbA1c 7%, 6%, 5%, 8%. The outcomes are totally different. There were different microvascular outcome in a patient with similar HbA1c. Another thing is DCT trial, which is the largest trial, which also predict is long back this glycemic variability. So HbA1c is not a complete expression of degree of glycemia, that is disease state. It's a poor predictor of hypoglycemic events, which also contribute to mortality. So HbA1c never detect the hypoglycemia, and that's what advanced and ECHO trial clearly mention. One thing very careful about hypoglycemia, which is indicator of the increased incidence of cardiovascular mortality. Therefore, the new models come for CVD is that ambient hyperglycemia, risk of hypoglycemia, and most important thing is the glycemic variability. That's a very important for the microvascular or cardiovascular disease. And what is the link between the glycemic variability and the cardiovascular disease, that one must try to understand. The better hyperglycemia basically lead to the sustained chronic hyperglycemia. HbA1c is basically detect the chronic hyperglycemia and will lead to excess glycation of hemoglobin, that is the Hb, that protein, and that lead to the microangiopathy. Other two factors is postprandial peak and the hypoglycemia that also lead to the chronic sustained hyperglycemia, especially PPG, while hypoglycemia contribute the glycemic variability, and ultimately both that lead to the oxidative stress and that lead to microangiopathy. Decode studies which done very large scale that itself suggests that mortality rate increases while increasing the fasting blood glucose level and to or post PPG. If you see the graph, there is clearly mentioned fasting blood glucose less than 110 and PP is less than 140 is less. As the day progresses, the chances of mortality is very high. Same thing, the postprandial blood glucose, which I had given the two examples of the small frequent diet or large meal, that give the metabolic stress in the body and that increase the oxidative stress, that leads to inflammatory pro-markers, ultimately that lead to endothelial dysfunction and that lead to the cardiovascular impact. That is a very important of the cardio. Various evidence are available. Various studies are, and very good well-studied studies are available which associate that mealtime glucose spikes in the risk of cardiovascular disease and mortality is high. Quant study, Decode study, lot of all the studies, diabetes intervention studies, all clearly mention that postprandial blood glucose level and even hypoglycemia, they increase the oxidative stress and link to the CVD. So that is all the studies mentioned there. Now how to measure the glucose variability in our clinical practice? There are three standard deviations, three parameters. One is standard deviation, second is the max, that is the mean amplitude of glucose excursions, and third is the mode, which is the mean of a daily difference between the day-to-day variability. Most commonly, below 2 they are required the CGMS data, but we can do in our clinic day-to-day practice is the SMBG. They require 10-15 data, then we can detect the standard deviations and we can find that the glucose variability, that is routinely we can advise to the patients. Therefore, there is a very good study done, that is a chronic hyperglycemia but not glucose variability determines the HbA1c level. That you should remember. HbA1c detect the chronic hyperglycemia. It's not a glucose variability determined by the HbA1c in a well-controlled type 2 diabetic patients. So study done to determine the relationship between HbA1c for hyperglycemia, and it was found that this study, around the patient with hyperglycemia around the 6 hours per day. That is more than 140. That another they experience 4.1 hyperglycemia episodes per day. 78% of the patients have exceed the PP blood sugar is more than 150, and therefore various meta-analysis by MAG or everything, it was found that it is a PPG or duration of hyperglycemia that is very important for the cardiovascular outcome. So conclusion of that study is that in well-controlled type 2 diabetic patient, HbA1c correlate with only the chronic hypoglycemia, not glucose variability. Chronic sustained hyperglycemia and glucose fluctuation, these are two independent factors. Chronic sustained hyperglycemia and glucose variability, they are two independent factors for the component of dysglycemia in the diabetes. Number of hyperglycemic episodes or peak after the postprandial is weakly associated with HbA1c, accounting only a small proportion of variability in this glycemic measure at the targets of HbA1c. And that is another repeating slide, same thing, postprandial hyperglycemia, Decode study and STOP NIDM, they clearly mention that post-PPG sugar is increased incidence of the cardiovascular disease. What is HbA1c? It is a glycation of the protein. And what is the pathophysiology of diabetes? It is a chronic hyperglycemia, increasing fasting blood glucose or postprandial blood glucose. Therefore, HbA1c represents the glycation. Therefore, its glycation of hemoglobin is not relevant to diagnosis of the diabetes. It delays the diagnosis of diabetes. It's a poor marker of pathophysiology of diabetes. Obesity and poor glucose level reflect the pathophysiology behind the diabetes better. It captures only the chronic hypoglycemia. The sensitivity of HbA1c is very poor to diagnosis of diabetes. It changes epidemiologically. It is inferior to compare to the fasting blood glucose level at the population level. And it detects the IGT is very poor. And the last, delay the detection of diabetes around when HbA1c is more than 6.5%, it identified only 30 to 40% of previously undiagnosed diabetes. So most of the patients are undetected. Therefore, it's the same biological marker we can use as a diagnosis of diabetes, and monitoring of diabetes might not have a positive effect on the CVD. A finished study that suggests that when HbA1c level is more than 65.5%, to diagnose the diabetes only the 39%. Remaining 61% newly diagnosed diabetic subject it's less than 6.5%. So that is a disadvantage of IGT patient is not easily detected. CVD is already discussed. Variability is very important. Inter-individual variability of HbA1c is very high. Ethnic populations also different in HbA1c value. That's very important. Various conditions which have HbA1c is not reliable, like anemia, chronic liver disease, chronic renal failure, variant of hemoglobin, disorder of albumin metabolism, and pregnancy, where the HbA1c is not a good marker. And one more thing which yesterday I found, HbA1c give the false low report when we use dapsone, antiretroviral therapy, ribavirin, Satron, which are commonly used for antibiotic. Excess dose of vitamin C and vitamin E will give the low value of HbA1c, which are routinely prescribed as an antioxidant in diabetic patient. And aspirin in a small dose also lead to the low HbA1c level. Another is falsely high HbA1c level comes when aspirin we use the large doses and chronic opioid use. So this is HbA1c. Standardization is not proper. Even in India, somebody used the Targoti method, somebody used the NICO method, somebody used the HPL method. Though standardization is very poor in India. That we already discussed the short-term 2 weeks glycated albumin and fructosamine level. Non-traditional marker we can also relate. They have related to cardiovascular disease. It's not working. So the summary of my talk is that HbA1c cannot detect the glycemic variability, either hyperglycemia or hypoglycemia. That is the first thing. It's a poor marker of pathophysiology of diabetes. It can only detect the chronic hypoglycemia. It's a poor sensitivity. It delayed detection of diabetes. Variability is very high. It is unreliable in various conditions that we have discussed. Therefore, what should we take from this discussion is that HbA1c is the only factor which contributes to diabetes is not a good. There is a glycemic variability is very important.